Hello, welcome back, guys. So, today our topic is ectopic pregnancy. Here is a definition according to DC Datta. It is implantation of fertilized ovum outside uterine cavity. It can be anywhere: abdominal cavity, ovary, fallopian tube, cervix, etc. So, most common site is fallopian tube, that is 95%, and in the fallopian tube most common site is ampulla, then isthmus, then most common non-tubal site is ovary. Then comes to risk factor. Previous ectopic pregnancy are the strongest risk factor for this. Then PID, that is pelvic inflammatory disease, most common disposing factor. IUCD users, it prevent the intrauterine pregnancy but not ectopic. Then tubal surgeries and sterilization failure. There are more chances of the contraceptives that are sterilization failures. Then ART and IVF. Now comes to clinical feature. In the clinical feature, there is classical triad, that is amenorrhea, abdominal pain and vaginal bleeding seen in approx 50% of cases. In case of ruptured ectopic pregnancy, hemoperitoneum can be seen. It irritates the diaphragm because blood collects inside the peritoneal cavity and cause the shoulder tip pain. Then syncope and shock are also can also be occurred. Shoulder pain is also known as Danforth sign. In case of unruptured ectopic pregnancy, the pain occurred and it due because of the stretching of the fallopian tube. Then there are some signs known as like decidua cast, cervical motion tenderness and presence of adrenal mass. What is decidual cast? In patient of ectopic pregnancy, progesterone is present in very less amount, so decidua is stayed in form of decidual cast made of decidua vera. Then cervical motion tenderness. When you are going to do pervaginal examination and touch the cervix, the patient is going to wince in pain. Then presence of adnexal mass. It is adnexal mass, not the adrenal mass. Adnexal mass. Then comes to diagnosis. The diagnosis is done on the basis of clinical basis, like complaints of symptoms and signs, but we also check beta HCG, and on ultrasound there is no intrauterine sac. Then if beta HCG more than 1500 to 2000 international unit per liter. So what is the concept for this? Beta HCG is present on for intrauterine pregnancy on TVS it is 1500, and it TS, that is trans abdominal scan, it 16,500 international unit per liter. So we check beta HCG level. If it is more than 1500, then it is ectopic pregnancy, and less than 1500 we repeat beta HCG after 48 hours. If it's double, then it is intrauterine. If HCG level decreases, then it is abortion. and if it is increases but not double, then it is ectopic. Then in ectopic the pseudogestational sac can be seen. Then there are various type of special forms like cervical ectopic. The criteria for it is Palman and Rubin criteria, and it causes the painless bleeding. Then ovarian ectopic, the criteria is Spielberg. Then abdominal ectopic, the criteria is Studiform. So these criteria are asked in INI and NEET PG also. In these, interstitial pregnancy is the most dangerous one, and late ruptured and massive bleed present. What is heterotopic pregnancy? Question asked. It is an intrauterine plus ectopic pregnancy. Increase risk in ART. Now management of the ectopic pregnancy. In unruptured ectopic pregnancy, we do the medical management and surgical management. The one comes expectant management. In this the wait and watch, but today is not preferred. So comes to medical management. Confirm the diagnosis with beta HCG and transvaginal ultrasound. Assess the hemodynamic status. If patient is stable, then it is eligible for medical management. So here is criteria. Ectopic mass less than 3 to 4 centimeter. No evidence of rupture. No fetal cardiac activity. Normal liver, kidney and blood counts. So what we do? We give methotrexate single dose 50 mg per meter square. Then check on day 4 and day 7. If fall in beta HCG more than 15%, then it is successful, and if it not means it is less than 15%, then we again give methotrexate injection and check on day 1, day 4 and day 7. If again it is less than 15, then we follow the surgical management because of failed medical management. Then what we do for surgical management? In surgical management, we in today's laparoscopy is preferred, and salpingostomy or salpingectomy we done. In case of ruptured ectopic pregnancy, in suspected ectopic pregnancy, patient is unstable and in shock, and immediate resuscitation is required. First, we do emergency management known as airway breathing circulation. IV bore IV lines are put, crystalloid and blood transfusion given, oxygen, and monitor vitals and urine output. After stabilization, we do emergency surgery. In emergency surgery, we preferred salpingectomy, means removal of the tube which is damaged. Then we do blood transfusion and control the hemorrhage and peritoneal toileting. After that, we do post-operative care. We monitor the vitals, hemoglobin and beta HCG. In case of Rh negative pregnancy, we give NTD, and then we do counseling and contraceptive advice. There are some complications, like in case of tubal rupture, patient can go into the hemorrhagic shock. Recurrence risk after one ectopic is 10%, and future fertility, it depends on the tubal status. So that's it for the ectopic pregnancy. I tried to do a short and crisp revision for you guys. Thank you.